Well, good afternoon, everyone. Welcome to November Ethics for Lunch. I'm Crowe. I'm the Director of Surgical Care and Chaplaincy here at Johns Hopkins Hospital. And I'm going to run through these initial slides here to introduce what we do here typically for Ethics for Lunch. So this is the accreditation statement. You can read along. I'm not going to read all this out loud. I'm just going to fly through these here briefly as an intro. But certainly this, if you register for this as a CME, it's 1.25 category 1 credits. And certainly we would want you to take advantage of this. The policy, you can read that at some other point. There really is no disclaimers, I believe, or any conflict of interest. Certainly are excited for you to attend and enjoy learning about our activity objectives. And again, nothing here that requires us to be disclosing financial interest or commercial entity relationships. Part of our objective today is to focus in on a faith tradition and a medical situation kind of colliding, which is something we in our department do face in our facility often. And this year we are sponsoring this related to our Jewish so to discover Jewish ethical, moral, and legal perspectives concerning determination of life support, specifically focusing on the ethical dilemmas surrounding extubation of a patient who is comatose. To learn about various legal interpretations and typical family dynamics, to gain insight into this challenging decision-making process, especially at the end of life. To learn about some legal interpretations about that. Oh, sorry, I read that already. Explore the spectrum of Jewish teachings about the definition of death, concerning brain function and the role of life support systems, determining end of life, and to discuss ethical principles such as dignity, sanctity of life, and pikuach nefesh, saving a life concerning end of life decisions. Okay, so confidentiality pledge. And here, I'll pause here, let you all text what you need to text. No, the next one. Thank you. This is one. You text code, thank God. And so to get this credit, type in your activity code. I'll leave this up here for a second so this can get done by everybody. Very good. I think those of you walking in here, if you want to register for CME, do it quick. The text number is up here. Oh, you're taking pictures, good. Yeah. Okay, and okay. So we thought we'd start with a little bit of data here about ministry with our Jewish patients. And so some data here that may be of interest. Johns Hopkins Hospital actually hired its first Jewish chaplain back in 2012. We've had the Jewish chaplain a part of our department before that, but officially on the payroll in a part-time capacity. Rabbi Schiavi was our first Jewish chaplain at Johns Hopkins Hospital. Our census for Jewish patients is hovers around between 40 and 45 Jewish patients per day, with approximately 10% of those being of Orthodox descent. And Jewish chaplain, our Jewish chaplain who's here with us today, liaisons often between the hospital and community rabbis. And sometimes community rabbis also include rabbis from other parts of the country, and they would in fact also occasionally globally. Approximately 80 patients per month are seen by our Jewish chaplain. And then also to mention, this is also a fun fact that our department does appliance tracking with refrigerators. So that we have 11 of these. Not all of them are always available, but portable mini refrigerators available for patients and families who want to adhere, obviously need to adhere to their dietary restrictions according to their faith. And so the majority of them requested are for kosher diets, so certainly have them available for halal diets for those patients who are Muslim. And we track them, we try to make sure we get them back and make sure that they're available. Our Jewish volunteers, we have 3 different organizations that participate at JJ, all supervised by our Jewish chaplain. They do hospitality and welcome for patients. They restock the food, the non-perishable food that we keep in our kosher pantry, which is currently kind of behind the scenes of the construction. But it is still at Blaylock 175. Their signs are there, although you have to really kind of hunt for it now, and certainly provide other resources for families. All right. So I want to introduce briefly our panelists. We're really happy that you all made it here and were willing to join us. Rabbi Pinchos Rabinowitz, Director of Clinical and Religious Services here at the Holding Baltimore, is joining us. Naftoli Rabinowitz, son of Pinchos, and our current Jewish chaplain here at the Johns Hopkins Hospital. Emily Johnson, nurse practitioner, pediatrics, certainly in the PQ and JHH. And Dr. Adam Schiavi, assistant professor, neuro anesthesiology. Thank you all for joining us and to discuss this case. All right. So we talked about goals and objectives already. Let's dig into this. All right. So Mrs. SL, 32 years old, involved in a severe motor vehicle accident 2 weeks ago, sustained extensive head trauma resulting in severe neurological injury. Since the accident, she's been comatose. Neurological examinations have consistently shown an absence of purposeful movements or responses to stimuli. Neurological assessments indicate a very low level of brain activity, but she does not meet the criteria for death by neurological criteria for brain. She is fully dependent on life-sustaining treatments, including mechanical ventilation and medications to maintain her function. Multiple imaging studies confirm extensive brain damage, indicating a grave prognosis for any meaningful recovery. So the medical team, consisting of neurologists, neurosurgeons, critical care specialists, they've all been closely monitoring her condition. But after thorough evaluations, the medical team has concluded that Mrs. SL's neurological injuries are severe and irreversible. They've determined that further aggressive medical interventions, including life-sustaining treatments, would be unlikely to lead to any improvement of the condition. The clinicians feel that her injuries are incompatible with a meaningful quality of life. The medical team, in consultation with ethics, has initiated some end-of-life conversations with Mrs. SL's family. But her care was really falling in 3 different categories here. One is this assurance that she will receive supportive care, focusing on her comfort and dignity. Medical team is committed to managing any pain or discomfort that she would experience. Quality of life, certainly conversations are focused on Mrs. SL's current lack of consciousness and a meaningful response, emphasizing the absence of any signs of awareness or interaction with her surroundings. The family share that from their perspective, they have a different view. They have a different view of quality of life. Within their tradition, their Jewish tradition, preserving a life is held in high regard, even in this situation. So this respect for their faith, the care providers show respect for the family's Jewish beliefs, understanding the sanctity of life in their tradition. The medical team has encouraged the family to share their thoughts, concerns, any cultural or religious preferences related to Mrs. S.L.'s care. The Jewish chaplain has been involved from the beginning and has helped to bridge this patient's beliefs with their own family's rabbi. The family did give permission for the rabbi to help them with the decisions, and the medical team was open to this additional person being involved. Okay, so the last slide here, the situation. In this particular challenging situation, the medical team remains sensitive and supportive, providing assistance, emotional assistance to the family as they navigate the decision-making process. If life-sustaining treatments were to continue, moving forward with the care and support of this patient would require a transition to chronic care soon, which would be a trach, a PG tube, possibly a ventricular shunt, and ultimately placement in a facility to assist with her level of care. If life-sustaining treatments were withdrawn, then there would be consideration for organ donation. So let me stop here and turn this over to our panel. I don't know if you all had a discussion of who would want to go first or second and so on. But there's 2 mics, and I do want to hand it over to you all to respond to this stage. Thank you.
Just off the bat, say it sounds like a very complicated case. Yeah. So just off the bat, we did, it was mentioned that she does not meet the criteria for brain death, which makes it a little less complicated from a Jewish perspective. Within the Jewish tradition, death is the consideration for death is based on cardiac death and not the brain, which might mean a lot of times can get very complicated if it's a brain death situation. I'll just preface by saying that in the Jewish medical ethics is ordained by God. It's a rabbi's, and by rabbi I mean a Torah scholar, not just a pulpit rabbi, but a real Torah scholar's job to know the law and to be able to take each case has to be dealt with on its own merits and try to fit the case to the law. It's sometimes, there are some leeways about considering the family's options, but there is part of it is the laws and trying to fit the case to that. But because she does not meet the brain death criteria, so we would not, based on what it did say about that she's not having purposeful and responsive to stimuli. It's I mean, I can ask you guys, but I'm assuming that she would not be able to breathe on her own at this case, which according to Jewish tradition, if the ventilator is doing at least 51% of the job, it would be considered like it's the person's lungs. So by Jewish law, we would not allow that person to be extubated because we are hastening the death. We're allowed in certain instances to not do things, to withhold certain treatments, but we would not allow this person to be extubated in such a case, which would make it complicated in that sense. But it's another hurdle to talk about brain death. So I'll just start with that. Anyone else has any comments regarding just brain death?
Well, she doesn't really meet criteria for brain death, so it's not really relevant to this case. If you're either dead by neurological criteria or you're not dead by neurological criteria. There is nothing in between. If you don't meet criteria, then you're not dead. If you do meet criteria, according to the laws of the state of Maryland, then you are considered dead. I think that this case highlights in a very dramatic way the interaction between technology and culture. We're dealing with it's essentially a very old ancient culture, and it's clashing with modern technologies that are moving at a pace that none of us can really understand at this point. Things are moving very, very quickly. And this gap that forms between technology and culture is really highlighted in this case. And these problems, and one of the reasons I'm so happy to be here is that these problems are only going to get worse as we get better in keeping people alive or their bodies alive or preservation of their bodies, whether they're legally dead or not. And it's up to the point now where it's really unknown what the artificial lifespan of a human is on full technological support that we have the capability of doing. It could be 50 years, it could be 100 years, we have no idea. And this leads to some pretty big problems that we can think about as more and more people run into this problem. How do you continue to sustain people who will not accept an extubation or a brain death diagnosis or something like that? That means perpetual support for somebody who is not going to get better, but also is not going to be allowed to die. And like I said, we don't know how long that's possible. What we do know is that technology keeps moving faster and faster, and we keep getting better and better, and that time frame is getting longer and longer as a result. And so I think this case is really highlighting this conflict between technology and culture, and I hope that we can explore that a little bit together.
Yeah, and I'll just add to that, that's a very important point, that as a Jewish chaplain, and that's a big point, big part of being a Jewish chaplain is to know where technology in the medical world has moved, and to be able to help the family and their local rabbis understand. For example, one of our Torah scholars had written in the 1960s that in regards to we wouldn't withdraw, but we are allowed to withhold. So he had written that, for example, with a ventilator, you can wait for the oxygen thing to finish, and then we don't replace that, which was fine in the 1960s. But today it's hooked up to the wall. Technology has moved on from that. And part of being a Jewish chaplain is to be able to help the rabbis understand where these things have changed, and to be able to help them understand. Today we use the same idea, but we'll work it out with other medications, for example, with pressors, with, and again, every case is very unique. We would sometimes allow at first to withhold the pressors instead, and allow things to go in that direction.
So instead of a terminal extubation, so to speak, you would limit supportive care not from a ventilatory point of view, but from a cardiovascular point of view, and then allow the person to die from that perspective rather than through terminal extubation. Yeah.
And allow the natural course of things.
Yeah.
No, I think, Adam, your words of culture and technology, like the clash or how they meet, and that is not just religious in nature either. Like, we see challenges with this situation in a number of faith traditions, and also those that don't identify with deities or have specific spiritual laws and preferences. So it's actually something that we encounter for a number of reasons and in a number of situations. And so just being able to, like, at the source, be able to understand someone's values, what's driving their decisions, what's important, in addition to survival, what else matters, what's motivating this, and being able to spend time with the family and with the people who they seek guidance from to help make these decisions is also important, because there's just really, everybody wants to live, no one wants to die. Like, those are like kind of like these two areas, but there's a lot in between. And, you actually need to sit with someone, and take the time to kind of piece all these things out to help figure out what's possible and what fits best for each family. So there's a little bit from me. Is it too early to open questions up to the audience to see if there's any questions that they have? Cool.
I work more in the organization called Rabinowitz, literally means visiting the sick. So we are more of a supportive organization. We're not involved so much in the medical. We try to help the family and people around them understand what they're dealing with and help. We try to help as well, the doctors as well, understand what the culture of the family. And what Emily said, I think it is very important when clinicians know what the values of the family is, and whether they're Orthodox or any other religion, Jewish or even not Jewish, but how do you see value of life? What is important to you, rather than, we have our biases, the way we want to live, the way we think life is important. And if I can't do this, I can't do that, I'd rather not, I'm important to people. But sometimes people have more of a spiritual look at life, and it's important not to impose, even unconsciously, not to impose what we think. If I just break down, I was doing with the case where the patient was metastasized cancer and end of life. He wasn't conscious, he was okay. He still had options. And the family, of course, wanted to fight to go, and continue to fight. And the doctor had a conversation with the patient, and the doctor said, this is what more or less the treatment is going to look like. And the patient said, I really don't know if I'm up to that. And so this conversation was the doctor and the patient without the family around. And my question was, did the patient feel it's all on him? Had they discussed it and included the family in the discussion? Maybe the patient would have felt stronger. Is it possible that some of the things the doctor said really scared him, really scared the patient? And he felt he just can't do it. So there's a lot of things that we have to consider when we're going to sit down with a patient and have a good conversation, to really know what's important to the patient.
And I'll just also, in regards to, like, especially when we talk about an ethical and ethics committee, with that, a lot of what we talk about is quality of life. And that is what you were saying is very important to understand what the patient's quality of life is, not just what our understanding of, it's futile treatment, it's the patient is never going to recover. Like, for example, within the Jewish Orthodox tradition, is the idea of even living an hour is something. So even that, to that extent, we have this tradition of you should live by these laws and not die by them. So there's a lot of things to consider from the patient's point of view, and not just, is this futile, what are we doing? The patient's never going to recover anyways. Why are we pushing this on them?
Well, I wanted to add just another maybe question here, because it was in our opening, which is around the family dynamic, which would be great if we can sort of ask every patient or family what the values, and they would tell us, and it would all just be, clear sailing there. I think we know that it's much more complicated than that. And certainly the more seriously conditioned, the more seriously news to digest. But I'm wondering if we could talk about some of the dynamics that I don't know, Naftoli, you want to take the lead on this, but a typical family dynamic, maybe we'll just say for an Orthodox patient, what kinds of things from the beginning, that are very important, because we understand the value around sanctity of life, but there are many more values around communication, the rabbi's involvement, your involvement, the medical team knowing that the rabbi's involved. Like, there's a lot of pieces of this. So I wonder if you can maybe just sort of widen the perspective of what to expect from the family.
Yeah, sure. So most of it I'll actually come from my father, and that had to go to that. So that he deals with the family. But just a lot of, especially amongst Orthodox families, a lot of them are very large families, and people live in different communities. Some family members might live out of town in Israel and New York and other places. And a lot of times I've seen, especially when it's an older patient, who has, let's say, metastatic cancer, a lot of times one of the adult children has their own rabbi that they're talking to, and the other family members are talking to their rabbi, and there's the mom's rabbi, there's a lot of family dynamics to work around, and it's some of why we do try to talk to the family a little early on. You, as close to the diagnosis as possible, saying, it might be good for you to talk to your children, talk to the rest of the family. What are your thoughts about it? Which rabbi would you like to have the discussion with? There is something called a halachic advanced directive, and the idea behind it is, we want to follow the Jewish tradition. We want to follow Jewish laws around these discussions. With some of what people fill in on that is, which rabbi would you like the team to talk to have that discussion with? And that helps a lot of times solve this issue of, having one adult son who has their rabbi in Israel who might have a much stronger opinion, a more stringent opinion than the rabbi from the family, from the rest of the family. But most of it, I will agree with.
And if you could also add to that, what happens when the rabbis disagree? And the family might be disagreeing, but when the rabbis disagree, how do you manage that?
So again, to preface that, you all know that there are different denominations in Judaism. Okay, Reform is conservative, is Orthodox. I can talk to the Orthodox. In the Orthodox, there are many different sects, many different opinions. Okay, yeah, okay. One Jew by opinion. Right? So there's been many rabbis to be made different. And I had a case where exactly what Naftoli was talking to, that it was one son who was from Gary, from this rabbi, he was from this rabbi, the other. So I did two things. First of all, the rabbis will understand each other. Let the two rabbis talk to each other. Instead of you coming with a message from your rabbi and you coming with it, let them be on the same page. Let the two rabbis speak together with the doctor, and then let them be able to convey one message. And in another case, I asked the families, there were many sons there and a daughter, and they were all sitting around the table, and everyone's like their opinion, their rabbi's opinion. And one of them got up and I got to call someone, somebody might have to call another rabbi. It's like, it was, so I said, who was your father's rabbi? Who did you turn to for the last 70 years? Like, why are you now looking for a rabbi that would, every little thing that every question he had in a lot matter, he would turn to Rabbi so-and-so. He's the one that should make these decisions for your father. Do you think that the last 24 hours of his life, he was like some rabbi he never met to make his decision? I don't think so. So, so again, family dynamics, but usually we're able to help the family come to speak in one voice. And that's part of the job in my capacity. What I do is to try to get, let's all speak in one voice. And it's not only just when it comes down to life, it's when everyone's calling the nurse and saying, how is doing today? There's one person that's going to represent the family who's going to call the nurse, not everybody, especially during COVID, but like everyone wants to know what's going on. And yeah, so it's very important to have unity. Very important. And it doesn't always happen. So.
I'll just add to that, to what you were asking. A lot of times there is, every rabbi has a rabbi that they turn to. There is no such thing as one rabbi who is the leader and knows it all, and we're all constantly learning. Each rabbi will, even the biggest rabbis will ask each other these questions. So then to answer the question about, well, if there's a bunch of rabbis who, yeah, so a lot of times there is that hierarchy a little bit. For example, Emily and I were involved in a case where there was a brain death situation, Orthodox family, and there were a few rabbis involved in that case. But they all said, well, whatever Rabbi Hyman says, we'll agree to. Because it's such a complicated case, it's so hard for them to interpret the law around that. And he's one of the, if not the biggest rabbi in our community over here. So they all said, whatever he said, we'll agree to. When we don't want to take that upon ourselves. So a lot of times you'll have that clear, even though there are a few rabbis involved, but they'll all say whatever this rabbi says or that rabbi says.
All right, so one more aspect here before we turn it over to the audience, and I know Anna and John Pinella are in our audience here. The question around organ donation, right? So this part of this case here, we don't know exactly how family was going to decide. If they did decide to withdraw, then on the table would be, can we have this conversation about organ donation? So I don't know if Anna would want to respond to that, but I think that's a key part also of this. In the event this happens, how do we have that conversation? What things should we know?
I'll start the conversation. That in regards to organ donation, one of the complexities is that we do, and like I said earlier, cardiac death according to Jewish tradition is death. So to donate a heart would be a problem. There's some circles that post-mortem would allow a donation of a kidney or a part of the liver, but also with a rabbi present to make sure that the body is treated respectfully and things like that. But in regards to living organ donations, that's a whole different conversation which I'll turn to you.
Yeah, so with living organ donation, specifically kidneys, there is an organization specifically for kidneys, and they, I think over 60% of the first kidneys that have been donated in the United States was done through this organization. It's actually considered an honor to be able to do that, and actually able to and willing to. It's a very high value. Again, I think that even within the organ donation, of course, as Naftoli said, we're not going to do anything that's gonna make that happen right now. But there are different rabbis that will say different things. I know there was a young woman who was killed in an accident in Israel, and the two daughters were killed. They donated everything, the way up to, California, everything was like they saved, I think, 5 lives in these two people. So their rabbi said, yes, go ahead, get whatever you can, take whatever you can. And other rabbis, there are rabbis that will say, we can't defile the body, we can't, there's a certain kind of respect we need to have after death, and we cannot, defile the body, and that's, but of course, I think everyone will say that if there is a case where the body, there's someone in front of you, so to speak, if you can say that you will have even an obligation to take even if whatever it is, to help save this other life, because the value of saving a life is always our priority.
Can you talk a little bit about the timing post-mortem? I know that once somebody dies, there's some guidance as to the timing before you have to prepare the body and things like that. How does that interfere or interface with organ donation, even in the different Jewish traditions?
Yeah, so in the Jewish tradition, we try to bury as soon as possible. Some even, like in Israel, they'll do a funeral at 2 a.m. even in the middle of the night. There's the idea we don't want the body to sit a full day, through 24 hours. So they'll do the funeral as soon as they can. In regards to organ donation, things would have to happen very, very quickly after that. Once a person is announced. Just to stay a little bit what you were talking about, also, how you broke the teeth a little bit on the work they call nefesh. And that's the idea of saving a life, the idea of sanctity of life and watching over someone's health is very important in Jewish tradition, which is why when it comes to living organs, there is such a high percentage of them that come from our community. And the same idea in Israel, for example, which the story that you had mentioned is in Israel, because there isn't a lot of people who are not Jewish, that would, again, organ donation in general, even in America, there's always a little bit of a shortage. So in Israel, we try to curb that. There is the idea that if the brain stem is not working, since the brainstem is the thing that makes the lungs and the heart work. So there are some opinions amongst rabbis, especially the Israeli rabbis, that if the heart is still beating and the lungs are still inflating, deflating, but there is no the person's brain dead, including the brain stem, it's not really that the person is alive, but rather the machines that are causing that. So some rabbis would agree that in such a case, you would allow the person to do organ donation, and including the heart and everything, which it sounds like was what was going on in that case. But there are a lot of different opinions around that. Over here in Hopkins, we actually have a very close connection with the local funeral home. And once they're called, they come down to the hospital within 90 minutes of that first initial phone call to pick up a body. We have arranged, because in Jewish tradition also, the idea behind respecting the body and things like that. We don't want to leave the body unattended. There should always be someone there saying prayers over the body. So because of that, you don't send the body down to the morgue, you just leave the body in the room and the funeral home will come and pick up directly from there, which is why they come within 90 minutes. So just to put it in perspective how fast things happen here. So if we do need to reach out to learn legacy, it would have to happen pretty fast.
I think once the decision is made that there's going to be a organ donation, let's say the doctor has to do it, it's not available until tomorrow. I mean they'll try to do it as fast as possible when the decision is made. It can take longer, as long as they do it as soon as they can.
And in the cases in which Naftali and I work together, what's something that's been really helpful is to involve the rabbinical community sooner versus later, and so that these questions can go straight to the rabbis. Like, is this something to even like approach the family with, like, where does this decision fall and these types of things? So to be able to work together to figure out how to navigate these sensitive questions that are going to vary from family to family and case to case.
Well, I think for the remainder 15 or so minutes that we have, I'm going to open it up for questions for the panel. And I can run a mic. You can share mic.
Yeah.
Thanks a lot. This is very useful for clinicians, especially I just joined Hopkins and I practiced for 18 years in a community without very few Orthodox Jews. Quick question, you had alluded to that even a day of life is important. How do you see, or how does the Jewish law see how one lives? So getting back to quality of life, but not just prolongation of life, but living life to the fullest or to the, for example, someone's values? How does the law step?
So, a person does not have to take upon themselves to suffer through the pain and things like that, which is why there is, with the advice of a very competent rabbi, they can make that decision to not seek certain treatments and things like that. But at the end of the day, there is the idea that the more someone suffers on this world, the less they'll suffer on the next. So every moment of life is precious, even laying in bed attached to a ventilator. These things are as well. But again, they're not required to say, yeah, I want to continue chemo and palliative radiation and things like that. They don't have to take that upon themselves if there is no, if it's not going to accomplish too much. But again, with the advice of their rabbi.
Just add to that is correct when the patient's conscious, the patient can make that on his own decision. I've actually involved in a case where the patient was a rabbi and he was having radiation with a lot of pain and Sharon Hopkins, and he said, leave me alone. I can't do this anymore. And he explained to him what would happen if he does continue the daily regimen. And he said, I know exactly what I'm getting into, and he expressed that he doesn't want to. It was his decision, and he said, I can't have that pain anymore, and that was it. And he passed away 2 days later. The problem happens when it's the family that makes the decisions, and they don't know. They might not know what their father would have wanted, or so that's when they have to turn to the rabbi and say, what are we allowed to do? What are we not allowed to do? That's where the rabbi would take the law and apply it to this specific case. And in every case is different. Every case is different. They'll look at the case and they'll say, okay, in this case, do this or don't do that. Discontinue this, discontinue that. It will not start, let's say, dialysis with the patient. From the kidney, let's start dialysis. No, we won't start dialysis. Again, it depends on whether or not.
I'd like to, can you hear me okay? I'd like to pick up on the point we talked about this life and the next. And the final analysis, the point of following the law, whatever that turns out to be by whoever's interpretation is it to maintain or sustain the optimal relationship with God, or does it have something to do with consequences in the Messianic era or other things like that? Would there be adverse consequences to an individual for violating the law in terms of how his or her post-earthly life would be affected?
So I agree. That is a very loaded question. So within Jewish tradition, there is that belief of heaven and hell. There is a belief in an afterlife and things like that. And yeah, there is this idea that if someone sins in this world, we are repaid in the next. And if someone does adhere to the laws, they'll be rewarded. The same as a lot of other traditions. In regards to end of life, we are on this. Part of our belief is that we're here to cleanse our soul, to come out better at the end of the journey. So because of that, the more someone goes through on this world, the more they'll come out clean in the next. But again, a person does not have to take that upon themselves extra above the, there are certain basics that we would tell someone to do. For example, hydration, nutrition, hydration, and oxygenation are the 3 basic things that we would, as much as it's not harmful to the person, because we are trying to extend life. So if, let's say giving someone whether it's IV nutrition or real nutrition when they're not, the body's not absorbing that can be harmful. So we wouldn't do that, but as much as it would be helpful for the body, to the person, we would require those three basic things. But to require someone to continue with palliative radiation or other treatments, that we would not require. We would not require someone to, we actually encourage for people to take pain medication. There is no reason to suffer extra. Just going through the treatments, that's pain enough. You don't have to go through the physical. I mean, even with the pain medication, there's still a lot of physical pain. But at end of life, when it can be counterproductive to the heart rate or things like that, that's when you need a rabbi to be involved. For example, the case that you had mentioned about the rabbi, when he was actively dying, he was in excruciating pain. And there was a question if to give him morphine or not, which I was in touch with his rabbi that him and the family asked us to talk to. And we both said, yeah, he's in excruciating pain. There's no reason for him to be in pain, even if that will cause the heart rate to drop. Which we gave him medication, and not long, we told the staff that they give him medication, and not long after that, he did pass away. So, there's this idea where we do what we can based on our human understanding of how things need to happen. There is no reason for him to be in pain, but then the rest is up to God to decide if that's going to be the cause or not, to a certain extent.
I'm thinking about your question, but also how it relates to some of the things that you just said. The suffering now leads to less suffering in the future. I'm wondering if people without proper guidance could interpret that as like you have a loved one who's laying in bed, clearly near the end of life, clearly suffering, and we're continuing to provide support, which in some cases could be continuance of suffering. If somebody in an uninformed position thought, well, we have to do this because the more they suffer here, the less they're going to suffer in the real world. Have you seen this conflict? And if so, or even if you haven't, how would you rectify that or think about that aspect of it? There's a conflict that's being fought forth, again, because of technology clash with culture. It's in the law, and a literal interpretation of that should mean this person should sit here and suffer for as long as humanly possible.
Yeah, that's actually a very good point. And I do see that every once in a while. Because growing up, we all have this basic understanding that every Jewish child will tell you, oh, yeah, we have to prolong life as long as possible at all costs. But then as you go to rabbinic school, as you get that training, you learn that there are certain limitations to that. So that's part of my job as a chaplain. When a family is having that discussion, a lot of times, they'll say, oh, the doctor was talking about the dialysis or whatever. Of course, we're going to do that. And I'm like, well, you really should be talking to your rabbi about that, because that's not so simple. And the patient had metastatic cancer and multi-organ failure. Why are you putting the patient on dialysis? Things like that. And it's just sometimes letting them understand that there is certain concepts where at some point in time, we do say that you should, in the Jewish term is sheval concept, that sit and don't do. You're not required to give the dialysis. You're not required to give these things. And not only are you not required, sometimes you shouldn't. When someone is in the active process of dying, it is sometimes even harmful to the soul if you're holding it back. The soul wants to leave, and you're giving the medication, you're continuing the heart, you're continuing the dialysis, you're continuing these other things, it's keeping the soul from going. So that's also painful for the soul, which is why we do encourage families to have the rabbi involved. We do encourage the family even to have, which we did mention in this case, to have the rabbi have a conversation with the team, even without the family present, just because we can be the team that then can be brutally honest with the rabbi and say this patient has a multi-organ failure, a lot of times we see families will focus in on the patient has a glucose or, something else that we're like, well, you missed the whole other part of the conversation where this is the patient that's, has all these other issues going on. Which is why it's important for the rabbi to have this conversation directly with the team and hear from the team what's exactly going on and being able to say, okay, in this case, there is no need for dialysis. There's no need for CPR. There's no need for intubation, things like that.
What about this case? Where the person felt the other one.
So,
They want to repeat the question.
say you were asking about what about this case?
The person felt the other one.
When a person is healthy otherwise. So this would be a very complicated case because of that. We would say probably, that there are certain things that we would not require. We would not require, let's say, possibly, we would say we can make the patient DNR. In regards to something that was mentioned is that we would have to try to move towards the more chronic chronic phase of care. So some of that would depend on survivability of those surgeries. If there's certain percentage of the patient might not survive those surgeries, we would say better not to. Even though that would allow the patient, if the patient survives, would allow the patient to then go on living for, like you were saying, who knows how many years. So it would depend on some of these things.
I'm sorry, regarding the question you asked, and continued on, I think it's more of a theological question. It's not so much of an ethical question. I think on the ethical side, I think our job is to make sure we are, as clinicians, to understand what the patient really wants. So I was once speaking to a doctor, and the doctor said, this patient will never have quality of life. This patient, comatose, this patient, nothing. So I asked her, what is quality of life? Well, he'll never be able to go back to school, the young teenager. And they'll be able to go back to school, they'll be able to play sports. She gave me a list of things that are important to kind of pick up her. So I said, you know what? This boy, all his life, has been learning Torah, studying the Talmud, he's been, and he is taught from when he was a small child that even when he's thinking about God, he's doing what he's supposed to do, even if he can't physically do anything. But even if he's just thinking about God. So do we know what he's thinking about? Like he's having the quality of life that's important to him. I said, maybe, I didn't say I didn't know, but I said maybe this person is having a certain quality of life. For you, quality of life is what about children running around in third world countries that don't have shoes for it? That quality of life, they're happy children running around. So what's to us quality of life? Not always quality of life. I think that's where the ethical comes in. So the clinician has to understand what's important to this family, this patient, what's important to him, and we try to serve him.
I have one question, but I want to make sure that anyone in the audience doesn't have questions, so that I don't want to monopolize your time yet, since you're priority.
Very interesting discussion. Thank you. Appreciate it a lot. I'm curious about, we've been talking about what constitutes life, quality of life. I'm actually interested also in the thinking on what constitutes technology, because there's some schools of thought where, even a process like the scientific method is a technology in and of itself. And obviously medicine is based on, scientific method, etc. So what in Jewish thought constitutes a technology that is intervening on the body? It's an external thing, and what is natural? Because if you prove that something can work, a healing touch, through the scientific method, again, through some schools of thought, that might be considered a technology. But I gather that's not the line of thinking that you're using here.
Yeah, and I think for our discussion that the idea of technology is anything that's, any real, anything that's not natural, let's put it that way. So let's say, a touch, a healing touch, that would be fine, but within the dying process, we actually try to minimize touching because we don't wanna, get in the way of that process. We don't wanna, sometimes we've seen, we'll turn a patient over and the heart rate will drop. So we don't want to cause these things that might get the heart rate to go one way or the other. So we will try not to touch the body during the actual dying process. But anything, for example, when we talk about technology, would be anything real, like intubation, setting up with dialysis, doing, running a code, and anything like that would fall into that category.
And I guess my question is, do you ever run into conflict between families and what religious guidance would be? So like maybe a family would state a preference of wanting to stop on things or not do things and ask their rabbis for guidance, and the rabbi comes back with a different answer than what the family does voice. How do you guys navigate those situations, and kind of what's our role within the healthcare team?
So for me personally, it's a little bit more complicated. From a legal standpoint, I'm not allowed to tell family, well, this is what you have to do. I can advise them, I can tell them, you should be speaking to your rabbi, but it's up to them to have that discussion. And to decide, like for example, I come from an Orthodox tradition, we wouldn't extubate, but there are Jewish patients who are not religious or other traditions that would allow that. And it's not my place to say, oh, if you're doing something wrong, but rather just support them where they are, as much as I can. But maybe you can talk more about the family aspect.
So, the guy doesn't want to listen to his rabbi. But really, I think it's up to the family to make a decision, and it's up to the medical team as to listen to what the family says.
Okay, no, that's helpful, thank you.
Yeah, we actually had a frustrating case where a family was not really listening to their rabbis. Like they said that the person they said their rabbi was, it was not possible for that rabbi to be their rabbi. He's no longer alive. He was 90 something years old from Israel. Does not really support people in that way. And they're like, oh, we have to talk to him. And so we just said, okay, you do whatever you need. And they didn't want us in the room. They didn't want us involved in any way, shape, or form. They distrusted us coming in as like, oh, we're coming from a different tradition. We're coming from a different. We're going to push on them to end things. Or the patient was at end of life really. We're coming here for a fifth opinion, which we do have those issues.
Well, listen, I know we're coming up here at our time boundary here, so I want to pause and thank the Berman Institute, our sponsor, who provided lunch for us. And I want to thank also Reverend John Pinala, who is here with us, raise your hand, John, who helped form this case that we're discussing. And certainly thank you to our panel. Appreciate it very much for being here and responding to this not so easy situation. So thank you. So again, this concludes our ethics for lunch for November, and I believe it's every third Tuesday. So next one will be December. So thank you all very much. Appreciate it.